Delay.
Okay, good morning, everyone. Good evening and good afternoon for various other countries who are joining in. We have a lot of speakers here. Today we have a very important topic, but let me introduce. We have our chair, Dr. Chong from Singapore. We have Ravi from Malaysia. He's a past national president for CMAAO. We have various other doctors from India. We have Dr. Pillai from World Medical Council. We have Dr. Sajjad from Pakistan, and yeah, that's all. And then we are live on various platforms. We have Dr. Jamal. Yes, we have Dr. Jamal as well from Pakistan.
Bangladesh.
From Bangladesh, sorry. Okay, so we have we are talking about long COVID today. We have Dr. Shikha Gupta. She is a physician from Pennsylvania, US. She is a pulmonologist from and a critical care from Excel Healthcare, US. Over to Dr. Shikha Gupta. She will present the topic, and then we will open the forum for everybody to ask questions. Dr. Chong, can you please invite her? Dr. Chong, I would also request Dr. Chong to chair the meeting. We also have Dr. Monica, which I just realized over here from US, and Dr. Nidhi Agarwal from US. Dr. Akhtar Hussain is joining from Australia.
Good morning, how are you?
Dr. D'Souza is joining from Australia as well.
Hi, can you hear me?
Yeah, we can hear you.
There's a lot of echo.
You're connected to two phones, is that the reason?
Yeah, hang on.
Yeah, it's all the number of devices actually, Dr. Chong.
Yes.
So one of the devices, you have to leave the audio.
Yeah. Is that better?
No, you have to leave the audio. You can't mute it. You have to leave the audio.
Give me a second. Give me a second. Sorry. Apologies. Okay. Sorry about. Did you hear me?
Dr. Chong, your device has a COVID. We can't hear you now.
Can you hear me now?
Yeah, okay.
Great. Hi, everyone. Sorry about that. All these technical snafus. I don't have a webcam on my new computer. I just bought a new Mac Mini, so I don't have a webcam. So I have to use two devices. Sorry about that. Okay, welcome everyone, and thank you very much again for joining us on a Saturday morning for this. This must be our 60-something week. I've lost track of Zoom meetings with regards to COVID. We have all learned so much from these sessions, and thanks to our past president, who had been the driving force of these Saturday meetings. We all want to continue these very important meetings. We have been kept abreast of the whole situation, and it's great that we have a speaker today, and forward to listening to her. I'm sorry, I didn't catch.
Sorry, no voice, Chong. Your audio, please do unmute.
Can you hear me now?
Yes.
Okay, thank you all. Thank you very much again for joining us. And this is our 60-something meeting.
This is 60th meeting.
CMAAO.
Yeah.
And it's such a privilege to see all of you and to join this meeting and to chair it and to welcome our speaker for today. I'm sorry. Maybe we'll let our speaker get on with her topic, and we'll all listen with bated breath to hear what she has to say. Thank you.
Okay. Thank you for inviting me to present today. I'm going to share my screen here. Second. Okay, can you all see my screen?
Yes, we see your screen, Shikha.
Okay. So today I'm going to be presenting on post-acute sequelae of SARS-CoV2, also called Pests. Let me just...
Shikha, we don't see the presentation. We are only seeing your Zoom screen.
Oh, okay. Great. So let's see.
Shikha, share your desktop, like the whole desktop.
Can you see
okay,
it
we
now?
can see now.
Now we can see.
Okay. I just need to, 1 second, minimize this. Okay, sorry. So I'm going to be talking about post-acute sequelae of SARS-CoV2, or also called Pests. I guess is there a lot of echo happening on my end too? Or no? Okay. So before we go on to learn more about what Pests is, I wanted to share this data from the recent WHO dashboard. And as you can see that it's encouraging that overall the trend in the world, the number of cases are declining, but still we're still having a lot of cases. This is from, is there a way, can you guys see the top of my slides or no? Like this part?
Yeah.
You can, okay.
We can start from the figure 1. We can see the first line.
Yeah, but you can't see the whole heading, right?
We can see till 21st, 2021.
Oh, okay. So, and this is the data till 23rd of May. And even on 23rd of May, there were still 4.1 million new cases happening and 84,000 new deaths reported. So what is PASC, or post-acute COVID-19? You guys might have heard the term long COVID, like Saurabh said, long haulers, post-COVID, et cetera, et cetera. So even a year ago, when we were only a few months into the COVID-19 pandemic, there were a lot of media reports where patients were reporting having symptoms months and months after their disease onset. So how do you define PASC? So as you all know, if this is time zero, or when patients have disease onset, all patients have had exposure within the last 1 to 2 weeks prior to their disease onset. That's called the pre-symptomatic phase, where if you test them for their SARS-CoV2 PCR, that's going to be negative. From the disease onset to the next 4 weeks, this time period is called acute COVID-19. And then anything beyond 4 weeks is called post-acute COVID-19. So post-acute COVID-19 is defined as having persistence of symptoms or development of sequelae, so new or worsening symptoms beyond 4 weeks of symptom onset of COVID-19, which cannot be attributed to alternate diagnosis. It is further subcategorized into subacute COVID-19, which is symptoms that patients have within 4 to 12 weeks after their symptom onset, or chronic or post-COVID-19, which is symptoms beyond 12 weeks of disease onset. So going into epidemiology of PASC. So I know this is a busy slide, but this was the first study looking into post-COVID-19. This was from Wuhan, where they evaluated patients 6 months after their disease onset. And as you can see here, even after 6 months, 76% patients were reporting to have at least one symptom, with the most common symptom being fatigue. This was another study from Michigan looking at 1,250 patients who were discharged from the hospital 2 months after that. And of the 488 of those patients that they had enrolled in the study, 32.6% patients had persistent symptoms, or 18.9% patients had new or worsened symptoms, with the most common symptom being dyspnea on exertion that 23% patients reported. Since that time, there have been many studies looking into the epidemiology of PASC, and I'm not going to go into details of that for the sake of time, but as you can see here, there was a very high proportion of patients who were reporting at least having one symptom many weeks to months after their initial disease process. So what are the risk factors for developing Pests? So as it's a relatively new disease, we don't have established risk factors. The field is still evolving, but from what we know as of today, there are certain lab values. So if you have elevated BUN, elevated inflammatory markers like CRP, IL-6 or D-dimer levels, having lymphopenia, they saw that patients who had elevated troponin level initially were more likely to report fatigue. Certain patient characteristics were also seen. Female gender, what we don't know about female gender is it that the females were more likely to report their symptoms or whether females were more likely to develop symptoms. Having history of anxiety or depression, obesity, age more than 70 years, studies which came out of US showed that minority population like African American and Asians were more likely to develop post-acute COVID-19. The studies so far have not shown comorbidities like chronic lung disease or heart disease or kidney disease, whether those patients are more likely to develop that or not. Then whether there were any characteristics of their initial disease presentation. So patients who were more symptomatic initially, so presence of more than 5 early symptoms, those patients had prolonged course and had post-acute COVID-19. There are conflicting studies whether there was any association between initial disease severity. Some of these studies show that patients who had more severe disease are more likely to develop Pests, but a lot of patients who had only mild disease and patients who never needed hospitalization also are reporting symptoms of post-acute COVID-19. There are some increased reports showing that patients who had a prolonged ICU stay or need for non-invasive or invasive mechanical ventilation are more likely to report these symptoms. What we don't know about this is whether this is actually post-acute COVID-19 or whether it was a complication of their ICU stay or whether they developed what's called post-ICU syndrome that we see with patients needing prolonged ICU. Now coming into clinical manifestations, or how do these patients manifest with? So this was a study from Paris, France, where they looked at different symptoms in both acute COVID-19 phase and post-acute COVID-19 phase, and they divided symptoms into 7 major categories. So around 73% patients reported major fatigue or exhaustion. 77% patients had some kind of neurological symptoms, which they further categorized as neurocognitive problems like having memory issues, mood or attention disorder, headaches, sensory issues like balance issues, tingling or burning sensation, swallowing or speech disorder, or autonomic dysfunction. Over 70% patients reported cardiothoracic symptoms like dyspnea, chest pain, chest tightness, cough, and palpitations. A lot of patients had muscular symptoms like joint pains, muscle aches, body aches, etc. Around 30% patients had persistent or recurrent loss of sense of smell or taste like ENT symptoms. A lot of patients had GI symptoms of nausea, vomiting, diarrhea, epigastric pain. Some patients had elevated liver function test, and then skin and vascular symptoms, including hair loss. So this was a study from University of Washington, and here you can see the dark blue bars report patients who had mild illness, so were not hospitalized, and the light blue bar are patients who had severe illness. And this was a much more long-term follow-up where most of the patients were evaluated till up to 9 months. And as you can see here, even patients with mild disease, a lot of those patients had post-acute COVID-19 symptoms, with the most common symptom being fatigue. This was another study done from Germany where they evaluated patients up to 9 months. The patients were seen 3 times at a median of 1.7 months, 4.3 months, and 6.8 months. And as you can see, even at the 3rd visit, a lot of patients still had symptoms, with the most common symptoms being loss of sense of smell, fatigue, shortness of breath, and loss of sense of taste. Many patients who needed hospitalization on the initial visit had increased risk of rehospitalization. There were two very large studies, one with more than 100,000 patients from US and another with 50,000 patients in the UK. And there was an incidence of 10 to 30% needing rehospitalization. In the UK study, they also saw that 10% patients who got discharged died after discharge. Risk factors for increasing risk of rehospitalization are older age, more than 65 years, discharge to skilled nursing facility, obesity, and having comorbidities like chronic lung disease like COPD, congestive heart failure, diabetes, and chronic kidney disease. So how do you manage this patient? The first thing is, when do you evaluate the patient? In an ideal world, if we did not have that many cases, you would want to evaluate every patient who had COVID-19, which of course is not going to be possible with the sheer number of cases that we have. So the current recommendation is, if it's a young, healthy person who had mild disease and did not need hospitalization and is asymptomatic, that person does not need any routine follow-up. An older patient or any patients who have comorbidities with mild disease without needing hospitalization should be evaluated 3 to 4 weeks after disease onset. This evaluation can either be done as a televisit or a face-to-face visit. Patients who had severe disease needing hospitalization should ideally be seen within a week of discharge and no later than 2 to 3 weeks after discharge. If patients have persistent symptoms beyond 12 weeks, so now we're talking about patients who have chronic COVID-19 or post-COVID-19, they should be referred to COVID-19 recovery clinic. So how do you evaluate this patient? You can start with basics. Like every patient, you should go over a detailed history and examination. Your history should include what their current symptoms are, including all different organ systems, as we saw that it can involve multiple areas of the body. What their comorbidities are and whether their comorbidities are well controlled or not. Medication history of what medications they're on, and getting hospitalization records. Hospitalization records are important. So like if they had received monoclonal antibodies or plasma, then you want to delay their vaccination by 3 months. If the patients are still on steroids, then we need to work with that. If they've received immunomodulators, they could be at increased risk of infections. Then almost all patients should undergo basic labs, like getting a complete blood count with differential, renal function, liver function, and coagulation panel. Based on what their symptoms are, you can do further lab work. If you're suspecting a cardiac disease, you can get a BNP or troponin done. If you think they might have had a PE, check D-dimer. If their main symptom is fatigue, you want to rule out hypothyroidism, check a thyroid profile. Patients presenting with predominant pulmonary symptoms like dyspnea and cough should get pulmonary function test done, chest x-ray done, and based on what your suspicion is, you can do either a high-res CT of the chest or CT angio. And we'll talk about this in detail later. If you have cardiac suspicion for cardiac disease, then getting an EKG or echo. If they have more of neurological symptoms, then they should undergo neuropsychological testing and considering getting in CT or MRI of the brain. So as we saw that post-acute COVID-19 involved multiple organ systems, it should be a multidisciplinary approach. At least in the US, most of these COVID-19 recovery clinics are run by pulmonologists, and we'll talk about this area in detail later. If they have neuropsychiatric symptoms, they should be seen. So all patients should be screened for anxiety, depression, post-traumatic stress disorder, sleep disturbance, and cognitive impairment. The role of primary care should be early referral to rehab, educating patients that this is not something that they're imagining and it's an actual disease entity, considering enrolling them in research studies and advocacy groups. A lot of patients do have normal kidney function, but some patients, as a complication of acute COVID-19, might develop acute kidney injury. In case that's happened and they still have some kidney dysfunction, they should be referred to a nephrologist. We, as of now, don't have much treatments for post-acute COVID-19, but one thing that has shown to improve outcomes is referral to rehab. And rehab consists of both physical rehab, which is doing light aerobic exercises and breathing exercises and gradually increasing the intensity of exercise, and doing behavioral modifications and psychological support. Unfortunately, a lot of these patients have anxiety and depression. Some of the patients might have lost their family members to COVID. They could have PTSD from being in the ICU or hospital for such a long time, and they'll really benefit from psychological support. If you're in an area where there is not established a robust outpatient physical therapy program, you can still advise patients to be active at home, try to go for walks, monitoring their oxygen level, and slowly increasing their exercise capacity. Now, let's say a patient's presenting with dyspnea more than 4 weeks after their disease onset. So what could be the few things which could be causing the dyspnea? So one is if they have persistent lung abnormalities. So if a patient had severe ARDS and now that is getting better, or if they've developed organizing pneumonia or pulmonary fibrosis. Patients could have developed PE as a complication of COVID-19. Just being in the hospital, they could be very deconditioned. What we say is if you spend 1 day in the ICU, that is equal to 10 days of rehab. So imagine if there's a patient who spent 10 days in the ICU, that's almost 3 months of rehab. It could be because of cardiac causes like myocarditis or stress cardiomyopathy causing congestive heart failure, neuromuscular weakness, especially in ICU survivors. They are at risk of having critical illness neuropathy and myopathy. If they were intubated or trach, they can have tracheal stenosis and they'll present with stridor and dyspnea. Or if they have any underlying lung disease, which was either diagnosed or not diagnosed prior to them COVID-19, they can have an exacerbation for that. So patients who are presenting with dyspnea after 4 weeks, which is not getting better, every patient should get at least a pulmonary function test, 6-minute walk test to assess their exercise capacity and whether they need oxygen or not, and a chest X-ray. And then based on whether you want to evaluate for their parenchymal lung abnormalities, you can get a high-risk CT chest, or if you're suspecting that there's a PE, you can get a CT chest with contrast. If you're thinking there's a cardiac etiology, then cardiac evaluation. We'll talk about some of the treatments for organizing pneumonia and pulmonary fibrosis later, but for most of the other things like deconditioning, neuromuscular weakness, etc., the main treatment is referral to rehab. So for cough, there's not really that much you can do. It's mainly supportive care. You can tell them to try over-the-counter cough suppressants. There is not that much role for inhalers. Some patients can develop post-viral asthmatic bronchitis, and they might benefit from being on inhaled steroids or bronchodilators. Now, some of these patients, if they were treated with steroids, can develop reflux, and that could also be a cause of cough, so you can evaluate for that. So this table is from the same study from Wuhan, which had evaluated patients 6 months after their disease onset. And they also did PFTs and CT chest. And as you can see here, a decent number of patients had abnormalities on their PFTs, with the most common being reduction in diffusing capacity. 52% of the patients who underwent CT chest had one abnormal CT pattern, with the most common pattern being ground glass opacities. So the term for these persistent CT changes is persistent post-COVID-19 interstitial lung disease. This is a study published from UK where they saw patients 6 months post-discharge, and they saw that at least 24% of those patients had persistent parenchymal findings. Of these 24%, more than 75% had findings which could be attributed directly to having inflammation of the lungs from acute COVID-19. The most common finding was bilateral subpleural ground glass infiltrates in the mid to lower lung zones, which we call as organizing pneumonia. Some patients can develop subpleural and peribronchial consolidations, traction bronchiectasis, and pulmonary fibrosis. Very few patients had other abnormalities like PE, lung infarct, pneumonia, lung nodule, etc. So these patients who had this organizing pneumonia or ground glass infiltrates, and if they had persistent symptoms, you treated these patients with steroids. So you gave them prednisone 0.5 milligram per kg, weaning them rapidly over 3 weeks. And this figure here, you can see what the average dose of steroids used was. And in almost all patients who had predominant ground glass infiltrates, they saw improvement both in their radiographic findings and on their PFTs. So this is one of their patients. You can see here there is subpleural ground glass opacities. And this was his CT after 3 weeks of prednisone. And there's a lot of improvement on ground glass opacities. And here you can see there's improvement in their pulmonary, in their FVC, diffusing capacity, and coefficient. So some patients might not have pulmonary, might not have ground glass opacities, but could have already developed pulmonary fibrosis. This was a case report from Michigan published a few months ago. And you can see here, in addition to the ground glass opacities, there is a lot of traction bronchiectasis, which is a marker of pulmonary fibrosis. So this patient at 12 weeks, I mean, the patient was already getting steroids. And then at 12 weeks, they started the patient on pirfenidone. And this is his CT after 5 weeks of pirfenidone. And you can see that there's a dramatic improvement in radiographic findings. Patient also had symptomatic improvement, was initially needing heated high flow oxygen and BiPAP. At the time of publication was on 2 liters of oxygen. In the US, we are not using pirfenidone or nintedanib like the antifibrotic agents. That was just a case report, but there are multiple studies going on to evaluate the role of antifibrotics for COVID-19 related lung fibrosis. Currently, the only indication for pirfenidone and nintedanib is if patients have IPF or if they have progressive pulmonary fibrosis. And rarely, if patients don't improve even 2 to 3 months after their disease onset, they might end up needing lung transplant. So now coming to the next complication of venous thromboembolism, as most of you guys are aware of, there's a very high incidence of VTE in patients with acute COVID-19, with reports going from 15 to 30%. Patients with documented VTE need at least 3 months of anticoagulation. What we don't know right now is that patients who are getting pulmonary embolism, whether they're going to end up getting chronic thromboembolic pulmonary disease leading to pulmonary hypertension. The controversial thing is, we know that patients who have documented VTE need 3 months of anticoagulation, but whether there is any role of thromboprophylaxis post-discharge or for outpatients. So this was a study done in UK where they compared their COVID-19 discharge with their regular medical discharge from 2019. And as you can see, the incidence of VTE was 4.8 versus 3.1 per 1,000 discharges, with the odds ratio 1.6. But as you can see that the confidence interval crosses 1, so the results were not statistically significant. So what is recommended is that for patients who are getting discharged from the hospital or outpatients, thromboprophylaxis is not recommended. Some people do say that if there are patients who are at very high risk of having VTE, like prior history of VTE, major surgeries, trauma, history of cancer, you can consider putting them on DVT prophylaxis. There are a lot of research happening in this field, and they're also looking at if you have elevated D-dimer levels along with these major risk factors, whether those patients should receive prophylaxis for up to 45 days. But as of now, the recommendation is not to routinely put these patients on thromboprophylaxis. And I'm talking about patients who are discharged or outpatients. Of course, every inpatient with acute COVID-19 has to be on DVT prophylaxis. Now coming to cardiovascular symptoms, so around 20% patients report chest pain and 9% report palpitations. If patients develop acute chest pain, then based on what's going on, you should think about ruling out pulmonary embolism or myocarditis. Or if it's more of like a chest tightness and if they're having wheezing, you should consider bronchospasm. For post-acute COVID-19 chest pain, the treatment is mainly painkillers like ibuprofen or other NSAIDs. If they're having chest pain and symptoms of dyspnea, etc., they might benefit from cardiac rehab. You guys might be aware of that many patients in acute COVID-19 might develop myocarditis or stress cardiomyopathy. All those patients should be evaluated by cardiologists and should get an EKG and echo repeated at 4 to 12 weeks. There are also some reports about athletes developing myocarditis. The recommendation for them is that they should abstain from competitive sports or aerobic activity for at least 3 to 6 months till their cardiac MRI is completely normalized and their troponins have normalized. Some of the patients develop autonomic dysfunction similar to POTS or postural tachycardia syndrome. They'll present with unexplained tachycardia, dizziness, orthostatic hypotension. The treatment is mainly conservative, like compression stockings, telling them to increase their fluid and salt intake, and referral to physical therapy. These medications have not been studied for autonomic dysfunction due to post-acute COVID-19, but have been extrapolated from the medications used for treatment for POTS. So some of these patients have been treated with beta blockers, midodrine, fludrocortisone, etc. Infections are not really part of post-acute COVID-19, but just with increased incidence of mucormycosis in India, I thought it would be something to put it here. I think these infections are still going to come into acute COVID-19 because most of the patients are developing within the first 4 weeks. The one infection that I wanted to mention was invasive pulmonary aspergillosis. So as you can see here, even early on, like very early on when initial reports came from China, they did report increased incidence of invasive pulmonary aspergillosis. Interestingly, aspergillosis has been reported with other viral pneumonias like influenza. They say that viral pneumonias damage the airway epithelium, they can hamper the ciliary dysfunction, and then with COVID-19, you get lymphopenia. So you're more prone to getting invasive pulmonary aspergillosis. Since the initial reports from China, there have been many studies from Europe and US also reporting invasive pulmonary aspergillosis. It's a little bit controversial because some people say that it's not invasive pulmonary aspergillosis, but it's more of a colonization. But to be honest, because these patients are so sick, so if you do isolate aspergillus, they have a positive galactomannan, they're all treated with voriconazole or similar antifungal agents. So for sake of time, I'm not going to go over all these complications, but as we talked about, patients can develop neuropsychiatric problems. They can, some patients rarely can have acute kidney injury leading to chronic kidney disease. They can have GI symptoms like nausea, vomiting, diarrhea, and some patients can have persistent liver dysfunction, musculoskeletal, and dermatological like hair loss. So in the US, a lot of in fact, I think almost all healthcare systems have started with what's called COVID-19 recovery clinic. This is a template of COVID-19 recovery clinic from Yale University. And this is more of a detailed thing because in addition to the clinic, it's also research and registry that they're making. But I thought if any of the countries want to start with this clinic, I can go over this in a little bit detail. So the referral pathway for the clinic is any outpatients who are having symptoms or patients at discharge are getting evaluated. Most of these COVID-19 recovery clinics in the US are being run by pulmonologists. So the first visit here is a telehealth visit done by a pulmonologist where you assess for symptoms and you assess if there are any extra pulmonary complications needing referral to other subspecialties. And because it's also a registry for research purpose, there are a lot of extra diagnostic testing happening, but most of these patients undergo high-risk CT of the chest, PFT, 6-minute walk test, and routine labs. Then the second visit is a face-to-face visit with the pulmonologist, and they're also assessed by physical therapy and occupational therapy. They're screened for neurocognitive changes, mental health disease, etc. And if they have any extra pulmonary complications, then they're referred to subspecialties. Then these patients are evaluated again at 3, 6, and 12-month period. They are all undergoing physical therapy, occupational therapy, and pulmonary rehab. They're getting PFTs and 6-minute walk tests done at 3, 6, and 12-month interval. And based on what other stuff is going on, they can get a CT angio of the chest, echo, etc. Then if the patients become asymptomatic, they're discharged from the clinic, and patients with persistent symptoms continue to be seen in the recovery clinic. So as with most things related to COVID-19, even with post-acute COVID-19, we have more questions than answers, but a lot of research studies are undergoing both in the US and outside the US, and hopefully we'll have more answers than questions soon. So in the end, to summarize what we know so far, so long COVID or post-acute COVID-19 is patients who are having symptoms, either persistent symptoms or new or worsening symptoms more than 4 weeks after their initial presentation. Here are the risk factors. So if they had more than 5 initial symptoms, elevated inflammatory markers, elevated BUN, older age, females, some pre-existing comorbidities. Then, as we talked about, the symptoms fall under multiple organ system and they should be evaluated in a multidisciplinary manner. The main treatment right now that we know works is rehab for the patients, but a lot of research is going on. Thank you.
Thank you, Dr. Shikha. Before Dr. Chong can speak, I would like to acknowledge the presence of Dr. Alvin from Hong Kong, Dr. Angelica from South Africa, Dr. Meenakshi from India, Dr. Rohit from US, and that's it. Dr. Chong, can you open the forum for the questions?
Thank you, Dr. Gupta, for that great presentation.
Thank you.
I just have a question before I open it to the floor. So it looks like there is a syndrome as well as obvious complications post-hospitalization. Is that right?
So it's not just post-hospitalization. So even patients who had mild disease never needed hospitalization. Basically, the syndrome is that even after 4 weeks of their initial disease presentation, patients are still symptomatic. We've had patients even months after their initial presentation, they have symptoms, and they could be vague symptoms of feeling fatigued, their exercise tolerance not being back to what it was prior to them getting COVID, still having dyspnea. Patients who initially had loss of sense of taste or smell, they still have those symptoms, and many other vague symptoms that patients can have. So if it's in the first 4 weeks, we still consider that as acute COVID. But if it's more than 4 weeks, then it's called post-acute COVID-19.
Okay, thank you very much.
Yeah.
And thanks for the answer. And I'd like to open the questions to the floor. Anyone has any questions for Dr. Gupta?
Dr. Gupta, can you just tell us that you have shown that this is more prevalent in the African American, Asian, and other races? So is there any correlation between this? Or we heard that they are more affected, actually more infected also. So what is the relation between those infection and this post-COVID symptoms? Can you just relate it?
Yeah, so as of now, because the disease is so new, we don't know if it is just that these patients are getting more severe disease or because, and that's more of the data from the US where these are minority populations. And unfortunately, during the COVID-19, a lot of data has come about disparity in care between what the care minority patients are getting and what other patients are getting, and whether those patients were not managed properly or they just had risk factors for having more severe disease, and now they're ending up having more of these post-acute COVID-19 symptoms. Like a lot of these minority populations are obese, so obesity is a risk factor. We don't know right now how much of this is association and how much is causation. Same is true for gender. Like for females, you don't know if females are more likely to report it or are females more likely to get it.
Fair enough. Yes, Alvin?
Hello. Thank you very much, Dr. Doctor. Thank you, Chairman. So excellent talk and learn a lot from your presentation. I'd like to ask, especially about the psychiatric presentation. Well, in Hong Kong, and in fact, there are not too many patients in Hong Kong. We only have 11,000 something. And many of those, 200 and about 15 had died, and most of the others had recovered, and most did not have a lot of severe physical derangement of their health, but some had felt they were still stigmatized. And I first of all, I'd like to ask if your patients or in the studies, stigmatization and psychosomatic symptoms still prevail after they recovered. Second, or if they are still having other residual symptoms, will psychiatric disturbances be common, and how serious are they in the study? And also, I just wonder if your presentation could be shared with us for those not confidential or unpublished slides. And another thing is that I'm a pediatrician. We don't have too many pediatric cases confirmed, in fact, and we don't have serious cases. We don't have MISC in Hong Kong for Asians here. But I remember in UK, there are studies, or the GOS study, they also have not too many pediatric cases, but according to their experiences, many of them in UK, in fact, are from South Asia and or Africans, not too many whites as well. And so I just don't know whether in your experience, for those children, do they have long-term symptoms, residual symptoms, or the parents felt any stigmatization after these children recover and return to school? Thank you very much, Dr. Gupta.
Yeah. Well, first thing is I would like to congratulate Hong Kong. You guys are doing so great with keeping your cases down. So to answer your questions, the first question was whether these patients were stigmatized and regarding what their psychiatric symptoms were. I think a lot of it is, so most of these patients, especially like minority population, what was happening to minority population in the US is kind of what was, at least because I'm from India originally, I know what's happening in India. It's like where multiple family members in the same household were getting infected. And a lot of people were getting hospitalized. There was a very high morbidity. A lot of people were dying. So I think there's a very high incidence of PTSD in these patients. Also, I do both outpatient and I round as an inpatient in the hospital. And I think patients were seeing people dressed up as like aliens, right? All gowned up, masked and stuff. They were having a lot of anxiety because of that, PTSD from that. They were so isolated, family was not allowed to visit them in the hospital. I think a lot of patients also are very anxious whether they're going to get reinfected and how severe the disease is going to be with reinfection. They've lost their family members. So there is a very high incidence of psychiatric problems like anxiety, depression, PTSD as a part of post-acute COVID-19. Going on to kids, so we don't treat kids, and in the US also, from the data that I know, the incidence of kids getting serious infection and MISC is very, very low. But I'm not, the studies that I saw, none of the studies had kids, it was all adults. So I'm not sure what the incidence of post-acute COVID-19 in kids is. And then I think you asked whether you can share my talk. Yes, you're welcome to share my talk.
Thank you very much.
Yeah, you're welcome.
Thank you, Alvin. Anybody else has any questions for Dr. Gupta? If not, Dr. Gupta, I'd like to ask you about this mucormycosis. Is it? I hear from my patients that one of the problems is because of these contamination of the oxygen concentrators. Is there any truth in that?
So I, to be honest, do not know that much data on mucormycosis. I've also just basically read what's out in the news, what small research studies are. I think and I'm not an infectious disease doctor, but from what my personal take on this is, I do not think this can all be blamed to steroids, because as a pulmonologist here, seeing patients with COVID-19 being admitted and being very, very sick, we've actually used pretty high doses of steroids for a while on these patients. So I think there is something else going on with these patients, because from what I know, it's not reported anywhere outside India, right? So whether it's contamination, I read somewhere that patients are doing a lot of steam inhalation, and steam can also cause damage to the airway, and whether that's causing it. I think it's more of a multifactorial thing, but I don't think they know as of now what exactly is causing it. I think steroids are contributing to it, but I don't think we can blame steroids for causing this mucormycosis pandemic. At least that's what I think.
Reason why I asked is because my patients are all freaking out from all the circulating photos and all that. So just wanted to get your view on that. Thanks. Anyone else has any questions for Dr. Gupta?
Dr. Chong, is there anybody here from India who can just tell us about the mucormycosis, because it is already declared there as epidemic there? Because
Dr. Pillai?
So if I may.
Yes.
We are also concerned here actually in Bangladesh. We are getting the cases. So we are much worried about it. And India is having a large border with us. So
Dr. Pillai or Dr. Minashi?
I have, that's been a very good presentation, very informative and organized. One question I would like to ask is, in these patients who come with sequelae, what is the percentage of the patients who are RT-PCR positive, and what is the antibody status of these patients who come with the complications?
So most of the studies have actually not looked into, like they haven't reported like PCR, but most of the patients do get PCR negative. So in the US, actually, I know like in many countries, patients do keep getting PCR done till their PCR becomes negative. In the US, it's not recommended. If your initial PCR is positive, they say not to repeat testing for till 3 months after your initial PCR is positive. And I don't think they've looked at what their antibody level is and whether there's any relationship with post-acute COVID-19. I did see a very interesting, and I think it's not a study, but like more of an anecdotal thing, where they said that patients who had post-acute COVID-19, some of those patients, if they received vaccination, their symptoms improved. But it's more like anecdotal and there's no real data behind it.
Thank you.
I have a query on chat from Dr. Vasudev, Monica, and she's asking about whether the COVID vaccination will change the outcome of long COVID.
You actually just mentioned that, yes.
Yeah. So yeah, I did, like, as I said, it's anecdotal and I saw some reports about it, but, and I'm not sure what like the pathophysiology for that would be, but some people have reported improvement in symptoms after COVID-19. And I don't know if those symptoms which improved, whether those were more of like neuropsychiatric symptoms, like if they were anxious and then their anxiety improved, I'm not sure.
I see. In that case, if they had mild COVID, if they had a very mild COVID, would it be also then, would they not have, would it reduce the chance of having long COVID then? If they had a very mild COVID?
No, actually, a lot of patients with just mild COVID never needed hospitalization, have persistent symptoms months and months, yeah.
I see. Okay, interesting. Thank you. Dr. Minashi wanted to tell us a bit about mucormycosis.
Yeah, so if I may, mucor, it's an organism, as you all know, it's ubiquitous in nature. So especially in India, so we do see a lot of these fungal organisms. And in fact, there was a study that said that if you do, sort of take a swab from, any of the patients, you might find some, amount of mucor in that. But whether or not it can actually cause a disease, that depends on a lot of host factors.
Yeah.
So at this point, I mean, let's not forget that India is also the diabetic capital of the world, and we do have a lot of patients who have diabetes, and that is a very, very important and a very crucial risk factor for developing mucormycosis. So that's just something that we need to keep in mind. There's also a lot of incorrect dosing of steroids that's going on, and even under treatment. So if you do under treat with steroids, you end up giving it for longer, and that's probably what's also contributing to it. There are some factors. So we had a severe oxygen supply, as you all must have read in the news, and so we had to resort to using industrial oxygen ultimately.
Yeah.
And so that it was not a medical grade oxygen, and that might have been the cause. You mentioned about the contamination of the oxygen cylinders. Well, I mean, of course, we do not have studies, but yes, that might be a contributing factor. We are all scratching our heads about what could be the cause of this. There's also a stipulation that you use those, those filter bottles in the oxygen concentrators, and that if you do not use distilled water and you're just using tap water, and that also might be a source. And lastly, soiled masks. Using masks over a long period of time and reusing them. That also, I mean, without sanitizing them with properly. So just washing a mask, as you all know, is not correct. But I think in the some of the patients, probably they don't do that. So that could also be a cause. We are seeing quite a few cases. The exact causation we don't know. We're still trying to work on that. But these are some of the causes why this could be happening.
Dr.
Thank you.
Dr. Meenakshi, I have a question for you. Actually,
Right.
I was just asking it before. That, do you find anything the difference between the villagers and the city dwellers? That I am just talking in terms of this, whether the decomposed organic material is having any link with that. Somebody
No,
there is
not
a lot of myths actually that cow dung or animal dung is a curable. Some in India it's going on. We have seen in the social media. So and YouTube also we have seen it. So do you find any link here, or the experts they're saying anything?
Are you talking about a link with mucormycosis or?
Yes, mucormycosis, right.
No, not really. We don't see that there are too many cases in the villages, or I mean, there's not much information about this, unfortunately, at the moment. It's something that's just happening. We're trying to find out what might be the cause, but I honestly believe that the number of diabetic patients are quite many in the country, and I think that is the. So there is, I've read a study which says that getting mucormycosis in the absence of risk factors is very, very unlikely. I mean, less than 0.4% is what they had reported. So and there are multiple risk factors at this point, especially like COVID itself is a immunosuppressive condition. So probably that could also be contributing. So yeah, I to answer your question, villagers, I don't think so. So a lot of fungal infections do happen in agricultural areas and in construction areas. So if that that might have a link, but I don't think that the regions are really playing a role in that.
Thank you.
I think
Thank you very much. Yes, Dr. Gupta?
Yes.
If I can just add, my only thing is that in the last wave that India had in September and October, steroids were still standard of care that time. And there was still the same patient population with diabetes and everything. So there has to be something different that is happening this time, because there were no, at least from what we know, there were no reports of mucormycosis last year, right? So it's just, that would make you think whether it's contamination from some kind of oxygen. I don't know. It's very interesting. It's scary, but I know a lot of people are looking into it, and hopefully they can pinpoint as to what's causing it.
Yeah. Thank you. As always, fungal infections, we always worry most about host factors. I think host really, because fungal spores are ubiquitous, they're everywhere all around us. So really a lot of host factors will likely be the cause. Anyway, I think one of the things we always do at the end of our, near the end of our session is, if there are no more questions, then we will always ask for an update from the region. So perhaps we'll just ask everyone for a quick update of what's happening in their region. Dr. Sajjad, would you like to start first?
Yes, thank you very much, Mr. Chair, Mr. Chairman. Actually, I just inform and I have a question also. Rather, in Pakistan, we have a good news that the number of cases is going down after having the third wave, and the government is doing very good for controlling the coronavirus. But I observed that after the people who have vaccinated are again infected and dying. Just my question is in other countries, do you have the same problem, facing the same problem? The people are having vaccinated, after 2-3 months, they get infected with the coronavirus, and within 4 to 5 days, they die. Although the number is very, 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 very low, but how it prevents and what, and we as a spokesperson of Pakistan Medical Association, we request the people that get vaccinated, and if you get virus after vaccination of coronavirus, you will have a very minor symptoms and you will not get the severity of the virus. But the people are asking why my brother is dead, because of even then he had a vaccine and then even then he died. Can anybody elaborate, please? Thank you.
Dr. Gupta, would you like to try?
Yeah, sure. So I can report from what I've seen in the US. Actually, in US, we've used mostly the mRNA vaccines, Pfizer and Moderna, and only recently started using Johnson & Johnson. And I think CDC published their data, and I don't have the exact numbers, but from what I remember, I think they said that over like 100 million people got vaccinated, and maybe like 10,000, like very few patients of those got disease, and most patients who got the disease, it was a very mild disease. So I think it was still like 90 or 95% efficacious to prevent all disease. And in most patients who got the disease was very mild disease, and I think it was less than 1% who had even severe disease needing hospitalization or death. And you don't know if those patients who developed severe disease, whether they were immunocompromised or had some other kind of risk factors which would make them like less, in which they would make the vaccine like less effective, like whether they were like transplant patients or they were on immunosuppressants. And I think for other vaccines, like AstraZeneca and all, unfortunately, the efficacy is not 100%. And like AstraZeneca was around 70%, and with the variants, the efficacy goes down. In most patients, still the vaccine would cause the disease severity to go down. So I think the message to the public should be is that in most patients, it is going to decrease the disease severity. But yes, there are going to be some patients, especially patients who are immunocompromised, who could develop a severe disease. So they should
Monica,
still
do you have
to be vaccinated.
Thank you,
Yeah.
Dr. Gupta. Monica, would you like to say something?
Yeah, I'm just going to add to that. I think in addition to the immunocompromised state, it's also an issue of comorbidities, which may not be immunocompromised state. And I also think this is an issue of variants. Now, if you're looking at your mRNA and the sequence that's involved, I mean, the beauty of those vaccines is that we'll be able to update them based on the changes in the mutations that are found in the spike proteins. But I think what you're seeing regionally across the world in terms of vaccine breakthrough cases might be a function of viruses, the variants itself. It's going to be the efficacy of the vaccines that are being used. And then it's going to be the prevalence of the underlying medical conditions that are, at a higher prevalence in those areas. And it may not be just immunocompromised. I think there's comorbid factors that are also playing a role. I do have another question for you too, since I'm asking, and that is when you're evaluating these patients with long COVID and you are doing the 6-minute walk test, you're doing the high resolution CT and you're doing the PFTs, in those patients who are presenting with dyspnea, what fraction of them are you actually seeing some pathology in any of these tests? Are they coming in with dyspnea and then these tests are coming out normal? Or are you actually seeing that there is going to be some abnormality in their high resolution CT, et cetera, that you had mentioned in the evaluation of those patients? Thank you. And by the way, it was a great presentation.
Thank you. In my personal experience, and most of the patients, and we don't see every post-COVID, in the institute that I work, every post-COVID-19 patient does not come directly to a pulmonologist. But in my experience, most of the patients that I'm seeing who are still profoundly dyspneic, and especially if they still are needing oxygen, they do have PFT abnormalities and they do have abnormalities on their CT. The important thing is how much recovery has happened from their initial scans. So as an outpatient, most of the patients do not have that much abnormality, but I also working in the hospital and round in a long-term acute care facility. And I have I can tell you almost every week that I'm there, I have at least 2 or 3 patients who've had COVID back in November or December. So many months out, still having a lot of ground glass opacity and a lot of patients having pulmonary fibrosis. Unfortunately, as you know, in the US, you cannot use any medication which is not FDA approved. I know in India, patients are getting pirfenidone and stuff. We are not using anything. We're just, if they have ground glass opacity, we treat them with steroids, or if they can be enrolled in these studies, which at least I don't think in Pennsylvania, there are that many studies looking at antifibrotic agents. And then most of the patients are unfortunately not even strong enough to get lung transplant. They're too deconditioned or they have other comorbidities.
Dr. Gupta, just a quick question. There's this organizing, I remember one of my patients had BOOP, bronchial obliterans, yes. And were on steroids for a year. Do you see this sort of situation where you had to give steroids for a year for organizing pneumonia?
Yep, so we usually don't give it for a year. In most patients, you wean it off within 6 months. And most of the patients who would need, most patients who have what we call as COP now, cryptogenic organizing pneumonia, which was called BOOP before, most of those patients need steroids for 4 to 6 months.
Okay.
But in the organizing pneumonia study, which was done on post-acute COVID-19, they only gave steroid for 3 weeks.
That's right. I was a bit puzzled why 3 weeks versus a much longer period. Thank you.
Right, but in my clinical experience, I have to say that I've given steroids for much longer than 3 weeks. And I've had patients who have recovered. The main thing is, as far as they had ground glass, they would recover. But once they start developing pulmonary fibrosis, then steroids don't really work.
Yeah, that's right. Thanks.
Dr. Sajjad,
yes, Dr. Chaudhary, maybe
Dr. Chong,
you'd like to, yes, sure.
Dr. Sajjad, because actually what I feel that Dr. Sajjad in Pakistan, they are using mostly Sinopharm, I think so far. Sputnik probably less number. So you don't have this AstraZeneca vaccine for Oxford, I think, so far. So we are also starting the use of Sinopharm here. So Sinopharm is having only just efficacy is only just above 50%. So maybe more infections you may get there. And I don't know even the mortality, about the mortality also, I don't know about the Sinopharm. What is the year? So
Dr. Jamal, we have Sinopharm and Sinovac and AstraZeneca. AstraZeneca given to above 40 age of patient. So we are using this, but the WHO have recognized the Sinopharm and the report says that its efficacy is 87%. I don't know what.
No. This is actually in Brazil. They have done it. It's only just above 50%.
Sorry, Jamal. Yeah. That is Coronavac from Sinovac. Sinovac is in Brazil, and that was 50%. But Sinopharm has 80%.
Yes.
Okay.
Yeah. recently there was excuse me, but I think recently there was a study that just came out on Sinopharm in JAMA, and the results were pretty decent. I remember it was about 80%. So
Yeah,
quite a decent,
78%.
yeah, quite a decent performance by Sinopharm actually.
Sean, can you repeat how much percent
remember-
you have said?
I remember it was 78%, if I'm
Yeah,
not mistaken.
there are
JAMA.
Okay,
two cohorts.
fine.
For the Beijing group is 78%.
Yeah,
So
78%.
another group from Yunnan or Suzhou is 72%. Wuhan.
Yes.
Wuhan group is 72%, but Beijing
Yeah.
group was 78%. But anyway, it's
Yeah.
more than 50%.
Okay, that's good.
Yeah. Yeah. So Jamal, maybe while you're on the line, maybe Jamal, maybe you'd like to tell us about what's happening in Bangladesh, so
Yeah,
we can
actually-
quickly round up everybody's what's happening in their home countries.
Thank you. Actually, Bangladesh is observing the lockdown also, but it's very loose actually. But we are concerned about our border areas where several districts are having a lot of infections, and its a positivity rate is more than 50%, 60% like that. So we are very much concerned because there is B1 that is Indian variant, which I say 617. Like that, and so we're very much concerned about this spreading of these infections throughout the country. We're much concerned. So vaccination at present is going on with the Sinopharm, just started, and it will continue. It will have a Sputnik vaccine also, although WHO didn't recommend for that still. So we are not getting the Oxford AstraZeneca. And near about 1.3 million people will not get the second jab of this Oxford vaccine. So that is also a concern here. And now the infections in other areas, other than the border areas, are lessened actually, the number of infections. So anyhow, I don't know, today is the last day of government decision, then whether they will extend this sort of loose lockdown, I must say, everything is going on. So that's the thing actually here in Bangladesh. Thank you.
Thank you, Dr. Chaudhary. And Dr. Pillai, would you like to update us on India? What's happening?
Thank you. Yeah, fortunately, our second wave seems to be receding. Per day, we used to have 4 lakhs of new cases. Now it has come down to 1.5 lakhs or 1.8 lakhs. And of course, the variants are responsible for fast spread of the infection, and that again is getting under control. With the variant, what we see is that whole family get involved, infected, and the whole family get admitted for treatment. And the duration, of course, is very short. Recovery also is faster, but at the same time, the mortality seems to be very high, and the pneumonia and chest complications and thromboembolic episodes happen so suddenly that before they reach the hospital, there are instances where death happens. And so the duration of infection is shorter, but the infectivity is higher. TPR remains to be around 20. But then definitely it is receding and it is coming down. And mainly because of the variant, this hike has definitely come. Immunization process, although slow, is happening. And as far as those who are immunized, we are using AstraZeneca and Covaxin, Indian-made vaccine. And the chances of infection is only 0.6%, those who are vaccinated. And those who already had an infection and not vaccinated, up to 3% reinfection have been reported. But the percent hype, more studies have to be done to know what the character is, what is the chances of reinfection, and even with vaccination, what will be the percentage who get infected. But then definitely those who are vaccinated, the symptoms are mild and mortality is almost negligible. Definitely vaccine does help us, and it has to be propagated, and on a larger platform with more of different vaccines. The process is going on in India. Thank you.
Thank you,
And
Dr. Pillai.
mucormycosis, again, it's a challenge that we are facing as a late complication. It is multifactorial. We cannot pin it down to one thing, maybe contaminated oxygen or the humidifier, the water you use for humidifier, the nasal tank that you use for a prolonged period, steroids, immunocompromisation. All these factors are taken into consideration. You cannot say it is because of one factor. Thank you.
Yes, thank you, Dr. Pillai. Very confounding. The whole matter is very confounding. Lots of confounding factors. Angelique, would you like to tell us what's happening, or Dr. Hussein from South Africa, what's happening there?
I will quickly jump in and then Dr. Hussein can follow up. Good morning. It was a very nice presentation this morning. We have, well, unofficially, we are in our third wave. Officially, we haven't heard anything yet. But our numbers are now increasing. We are now seeing the last 4 days, our numbers being around about 4,500. The past 24 hours, it was 4,576. We're also behind, our death rate is also on average of about 100 per day now. Yesterday was 123, and we are behind with vaccinations. We have only so far managed to vaccinate around about 408,800 healthcare workers. And since we started with our over 60s the last 2 weeks, we have only managed as well to vaccinate 400,000 people above the age of 60. Just want to comment on the vaccines and the breakthrough. So what we have seen now with Johnson & Johnson under the Sasonke project is that we said that after 2 weeks, the patients, you would have enough antibodies, but it seems that you can, it only starts to develop after 30 days. And yes, we are also seeing breakthrough infections, and they are busy with a study on that. And for the other countries out there, you know, you have to be careful with which vaccine you are using, as not all the vaccines are effective against the South African variant. We will see what Pfizer will be doing, because now in our second study, or in our second phase with the 400,000 people that we have now vaccinated above the age of 60, we will now start to see how effective the Pfizer vaccine is against our variant. So I think the problem in your countries are lying with the South African variant mostly. And what we are seeing now in the third wave, again, very fast, still our South African variant, very fast spreading. Young people not very sick. Problem is they are the spreaders because they don't want to quarantine, as they are not sick. Some of them are self-employed, and they don't listen and go back to work. The people, as we all know, with the data are still the same, above 65. Comorbidities doing not as great as the young people. And this is my 5 cents worth for this morning. Thanks.
Thank you, Angelique. Dr. Hussein?
Thank you, Dr. Chong. It was an excellent presentation by Dr. Gupta, and something new learned today, and especially post-COVID clinic. I think that is very important for follow-up and long-term follow-up. In South Africa, Angelique has mentioned most of the issues and challenges. The only thing I like to add, we are seeing some province like Johannesburg area, Bloemfontein, the numbers are very high, and other province, the numbers are very low. So we are just hoping it don't spread all over the province. Thank you, Chair.
Thank you, Dr. Hussein. And Alvin?
Dr. Chong,
Mr.
yeah, thank you.
Dr.
I have
Chong?
to jump in because I have to leave. Can I jump
Okay.
in? Okay,
Yes,
thank
please.
you. Now in Hong Kong, we'd like to ask all of you your expert opinion. In Hong Kong, we have 0 cases for the past week, but then we find it very difficult to boost up the vaccination drive. Many people are very hesitant here. So for already 3 months, we only had about 15% of the population vaccinated. So shameful. And now, what are the incentives to boost up the vaccination drives? Some of the experts had said that if the people had been vaccinated, they could be allowed to take off the masks in the public. Of course, not in the dangerous, very infectious places like hospitals, of course. But then in the general public, some experts would suggest that after vaccination, people could be allowed to take off the masks and could be exempted from the regular testing. So after hearing from some of your updating, there are some breakthroughs after vaccination, although many of those confirmed cases after vaccinations might be mild, but still there are breakthroughs. So what do you feel, colleagues? Do you agree with our experts that who had suggested to allow those people vaccinated to take off masks and to be exempted from testing? Do you think this sort of incentives are safe? Just like to ask you, the chair, could you
I'll open it to the floor.
Yeah.
This difficult question. I think we're dealing with sort of like, what's the word? Freakonomics, is it? You know, where you're dealing with kind of human economics and incentives, perverse incentives. Yeah. I think it's very, very difficult topic. Anyone has anything to say about it?
Well, Doctor, thank you.
Yes, Dr. D'Souza, yes.
Yeah, look, I personally think that wouldn't be a good incentive because you in Hong Kong have, had already had this issue about masking, where the medical association wanted masking, and the initial story of WHO saying no need for masking. Finally, you come back to masking. There's already hesitancy, questions in the public on the veracity of what the doctors, the medical profession is advising. And now if you give them an incentive, you take the vaccine and don't wear a mask, I think there is a psychological inference of which will certainly not be productive in terms of the what the medical workforce is trying to achieve. So that's my
Can I just suggest one? Can I just suggest
Dr.
one?
Chaudhary, yes.
Yes, it's my mind actually. This will happen actually here, and a lot of actually multiple incentives must be there actually to work. You do not know which will work for whom. That is I don't know whether the financial incentive also may be the factor also in some cases. And actually, if the people actually know that yes, this will be a great help for their foreign tour like that. Yeah, this they have to have these vaccine passport like that. So they must be vaccinated fully to get that passport if they want to go abroad or somewhere else like that. So yeah, this is actually this will work some. And problem is that if you do not see the this destruction like this casualties, then these people will not be encouraged actually. So this has to be in that form that you have to be vaccinated if you want to continue this thing. Whatever you have mentioned also, that has to be also there. But I have seen in India probably, I think some the parliamentarians also, they have just encouraged the people. Just I'll give money and they are going there, because a lot of illiterate people are there in India, so they got attracted there by the money, so they got a vaccine. Yeah. Which I have seen in the newspaper and other media actually. So that may work actually. I think this way. Thank you.
Okay. Yeah, thank you.
Thank you,
Can I
Dr.
say something?
Yes, please.
Please.
It is actually a very, thanks for mentioning it, Dr. Chan. It's a very controversial topic in the US, despite having, I think in many states, like I'm from Pennsylvania, and more than 70% adults in Pennsylvania have been vaccinated fully. Actually, CDC, I think a few weeks ago, made the new recommendations that if you are fully vaccinated, you don't have to wear a mask, even like going indoors to the stores and stuff. And they say that the incentive for coming up with these new guidelines was to incentivize non-vaccinated people to get vaccine. The difficult thing is when you're in a store, you can't tell who's vaccinated and who's not vaccinated. And unfortunately, I feel that a lot of people who actually got vaccinated were the people who were wearing masks. And a lot of people who are not vaccinated, some are hesitant to get vaccinated, but some are those people who were not believers in COVID and never actually wore masks. So a lot of us here, despite being fully vaccinated, still wear a mask. And then it's like kids, because kids are not vaccinated, and you don't know, vaccination still causes breakthrough disease, and you don't know if vaccination prevents you from being a carrier. So you could be a carrier, an asymptomatic carrier, and infect your kid. But I think a lot of universities here are making vaccinations mandatory for the college students. So a lot of like private companies might make it mandatory, but it's a very controversial topic of whether you can offer patients, like people, financial incentives or some kind of incentives to try to get them vaccinated. So I feel like, as I think Dr. Chaudhary mentioned, like if you see what these patients are going through, like there should be no vaccine hesitancy. Like everybody should get vaccinated because it's a devastating disease.
Yeah. Well said, Dr. Gupta. Thank you. And Dr. D'Souza, can you just update us what's happening in Melbourne? Then we can wrap up because we are actually running over time. Thanks.
I know, and Dr. Chong, you have an interest in Melbourne, and so good. Look, a couple of things. One is that Victoria, Melbourne, we went 83 days without a single case. In fact, all of Australia didn't have a single case. And we, in the last 10 days or so, we have got the Indian variant or what the mutation, but I think the first one, whatever it is, this has driven us into it's certainly now. I was just reading the potential for transmission is more than 150% greater than the British one, the UK one, and that has led to snap lockdown. Today is the second day of a 7-day lockdown where we never had a single case, and now we have, I think today, 35 cases from that one, the Indian that one, and so they mortally try. The experience is that it's so very fast. Within 24 hours, it has moved to. We've got now 180 places that it has jumped sites that are of importance. And so yesterday they did 58,000 tests and got five positive. The day before it was 48,800 cases and I got 4. So anyhow, it's at 35. It's supposed to be a 7-day snap lockdown, but I don't know. It will be reviewed, and that's the situation but it's only in Melbourne. Only the rest of Australia has no cases at all. Yeah.
Thank you, D'Souza. Just update everyone on Singapore. Singapore, same thing, because of the 1617 variant coming through to our airports. We have very good contact tracing here because we use technology, and we found that just to reiterate again, I said this last week. The first case was symptomatic on 4th May and the 4th generation on 12th May. So in 9 days, it went through 4 generations of spread. So that's how fast the variant is. The serial interval is now maybe 2.5 days, as opposed to previously 5 to 6 days. So we are dealing with it. we're into our second week of our mini lockdown, and we managed to bring the unlinked cases down to 2 to 3 a day. So we are hopeful that our mini lockdown has worked, just like what's happened in Melbourne and Sydney previously. So we are doing the same thing, mini lockdowns. We've hit about 70,000 tests a day, and vaccine is accelerated now. We're trying to get everybody vaccinated by August, which is our national day. So that's basically what's happening in Singapore. But our mini lockdown seems to be working like what you guys did in Melbourne and Sydney.
Yeah.
Thank you all so much. We've overrun our time, so thank you very
Dr.
much.
Chong, we would like to.
Yes.
We want to end this meeting. We have another meeting on
Yes.
micromarstosis.
Yes.
From stakeholders of Heartcare Foundation of India. So we are running out of time.
Yes.
This is the longest meeting we ever had, I think.
Sorry. Okay. Thank you, Dr. Gupta, for your brilliant presentation, and everyone for joining us. So we have to get off now, and thank you all again. I look forward to seeing you all next week on Saturday. Brilliant presentation, Dr. Gupta. We really, really enjoyed it and learned a lot.
Thank you for giving me the opportunity.
Bye.
Thank you, Dr. Gupta.
Okay, bye-bye. Thank you.
Thanks.
Thank you.